Introduction. The role of the ambulance service and paramedics has had to adapt and expand due to challenging circumstances within the NHS. Due to high demand in emergency departments, the drive has been to reduce emergency department admissions and use alternative care pathways. This drive has led to the need for advanced paramedics. Clark 2019b. Initially, advanced roles within the ambulance service were mainly clinical leadership or management based. Brown 2017. However, over recent years, paramedics working in advanced roles have a much wider opportunity to work in urgent and emergency care and primary care settings. Crouch and Brown, 2018, Health Education England, 2021. This has created the much wanted job progression that many paramedics look for and find limited within the ambulance service, Clark 2019b, but leaves paramedics working in advanced roles in areas that they have very limited experience in. The need for advanced roles for practitioners from various backgrounds, nursing, paramedics, pharmacists, etc., has come about due to various reasons such as budget pressures, rising patient demand and expectations, shortage of doctors, and the European Working Time Directive limiting doctors' working hours, an ageing population and cuts to social care. Crouch and Brown, 2018, Williams, 2017. These advanced roles have been hailed as cost-effective, safe, and can help overcome the workforce shortages and demands, Williams 2017. However, there are many variations on the role and vague job descriptions, which is becoming problematic for those working within these roles, Crouch and Brown 2018. I previously worked for the ambulance service before progressing into a clinical practitioner role at the Urgent Treatment Centre, and I'm currently studying to become an advanced clinical practitioner. This assignment will consider advanced paramedic roles within urgent care services and discuss the macro, meso, and micro effect on this issue, the skills and competencies required for this role, and the opportunities and potential risks, and an action plan for the future. The context of the issue. Macro. As mentioned, the NHS is facing sustained pressure from many things, including budget constraints, rising patient demand, and increased costs. William 2017. To try and combat this, in 2014, the NHS brought out the NHS 5-Year Forward View, NHS England 2014. The ACP programme was one of the initiatives formulated with the aim to create a more diverse and multidisciplined workforce that utilises and develops the skills of experienced clinicians, Brown 2017. Lloyd Rees 2016 also states that political and economical drivers have also influenced the decision to develop and utilise medical substitution roles as a way of rectifying the increased demands on emergency care. Crouch and Brown 2018 would disagree with the use of medical substitution. They identified that ACPs are part of a multi-professional workforce and a complement to the existing medical workforce, not a replacement. Over the years, the paramedic role has expanded and increased with increasing demand for emergency services in and out of hospital. Advanced paramedic roles began to develop in response to this, Clark 2019b. In 2018, NICE recognised the value of advanced paramedics as and the part they can play in easing pressures on emergency departments, and they called for further recruitment, Dean 2018. Over the years, there's been multiple services set up to try and assist with the demand of GP practices in primary care and emergency departments. This has been in such forms as walk-in centres, urgent care centres and minor injury units. They're all offering different levels of services. This has caused confusions for patients trying to access appropriate services, NHS 2021a. Urgent treatment centres is the name that has been brought in with the aim to provide a set of services across the country and considered a Type 3 A&E, NHS 2021a. Meso. Various ambulance services developed their own advanced roles for paramedics, from critical care paramedic for patients involved in major trauma and cardiac arrests, to emergency care practitioners, ECPs, or paramedic practitioner for assessing patients that are suitable for alternative care pathways, Ranke 2018. These roles have been developed differently across different ambulance services, and there is still felt that there is a lack of progression within the ambulance service, Ranke 2018. Micro. Clark 2019b found poor career development and physical demands were reasons many staff gave for leaving the ambulance service in favour of hospital positions. Ranke 2018 identifies increased risk of experienced mental health problems, staff shortages and high high sickness rates as challenges paramedics are facing within the ambulance service. I surmise that these are also reasons that paramedics are moving into primary and secondary care. Paramedics have been found able to work at the same advanced level as advanced nurses, and as they are already experienced in examination, assessment, diagnosis, and treatment plans. In 2018. Eaton et al. 2020 identifies that there is insufficient detail regarding the clinical contribution of paramedics in primary and urgent care settings to make any conclusions. However, as discussed, paramedics are working at the same level as advanced nurse practitioners, which are employed widely and are increasingly accepted by medical colleagues. Lloyd Reed, 2016. During 3 qualitative studies, it was identified that there was a genuinely positive attitude to the role from medics and nursing colleagues, and it was felt that they had a positive impact on patient care. Williams, 2017. There were some concerns raised in regard to the interprofessional tension due to blurring of professional boundaries. However, Higgins, 2015, argues that this is exacerbated by the lack of understanding of advanced practice roles, partly due to job titles and lack of clarity of the scope of practice of the role boundaries. Clark, 2019A and 2019B are both qualitative studies, which is traditionally thought of as low quality research. However, the aim of these studies was to find out more information about paramedics leaving the ambulance service in favour of emergency departments, therefore an appropriate research method. Each study has 8 participants from 3 roles across 5 emergency departments, which is an acceptable cohort for qualitative research, and they did not identify any bias. This is good research and is useful to understand paramedics making these transitions. However, we're not able to make any meaningful generalizations about what this means for the wider paramedic population. This may be possible via a literature review, such as Williams 2017, which is a literature review of advanced practitioners working in emergency care. However, this review is several years old now, and the role has advanced and changed even more during this time. Also, the review has found that only 3 articles were directly relevant, and all 3 were qualitative method studies. They produce some useful insight if we bear in mind that 2 are from 2006 and 1 is 2016. Skills and competencies. As a trainee ACP working in urgent care, there is not a clear set of skills or competencies either in my job specification or nationally. The ACP role does not differentiate between nurses, paramedics, or other healthcare professionals. They are all expected to be able to perform at the same level. The summary of my job description from my employer states you will be responsible for the clinical assessment, treatment and/or referral or giving advice as appropriate to both adults and children presenting with a wide spectrum of clinical conditions, either within one of our primary treatment centres or whilst undertaking a home visit. Derbyshire Health United, 2021. It is vague in regards to the specific clinical skills and competencies required. The description goes on to outline other areas such as management, education, research and leadership to encompass the 4 pillars of advanced practice. The role falls somewhere between the competencies and skills of advanced practitioners working in the emergency department and those in general practice. There are varying degrees of expectations of competencies of ACPs working in general practice, from limiting their scope to minor illness and acute presentations to as far as being able to manage the same cohort of patients as general practitioners. Whereas the emergency department setting, the Royal College of Emergency Medicine 2019 have agreed upon and published a framework with competencies and credentialing pathway for emergency care advanced clinical practitioners, ECACP. It has been modelled on the first 3 years of emergency medicine training, with some competencies excluded, such as anaesthetics and intensive care medicine. ECACPs can look after patients with a wide range of pathologies, from life-threatening to self-limiting, but they are limited to selected clinical areas or presentations that are common to acute care within the ECACP curriculum, the Royal College of Emergency Medicine 2019. This curriculum is focused on the emergency department, so only partly relevant to working within an urgent care setting. On a micro level, I've been unable to find anything relevant to paramedics working within urgent care. However, Brown 2017 and Clark 2019b found that paramedics working in advanced roles in the emergency department found that they had transferable skills for physical assessment and diagnostic reasoning and for managing severe emergency situations such as stroke or dyspnea. Clark 2019b found that paramedics identified difficulties in adjusting to managing multiple patients in ED and found working in ED a steep learning curve. Opportunities and risks. Since 2019, paramedics have been given the right to study for the non-medical prescribing qualification, NHS 2021b, which has opened up even more opportunities for paramedics in advanced roles in the hospital and in general practice. Clark 2019a identifies that opportunities exist for future role expansion within ED into areas such as resus majors and peds. As previously discussed, paramedics working in hospital have found the transition challenging. Clark 2019a identifies that there should be more comprehensive induction program to bridge the experience and knowledge gaps, such as functioning of the hospital, emergency department environment, and referral pathways and specialities. Hooks and Walker 2020 discussed that the ACP role has been driven by lack of medical professionals in both acute and primary care. The role has evolved to meet the specific needs of individual areas, resulting in variations in roles and job titles. They go on to identify this as problematic, as colleagues and patients do not understand the roles of their remit. They also identify concerns of ACPs being taken advantage of due to this. Crouch and Brown 2018 discovered the lack of standardisation of new advanced roles has made it difficult to analyse research on safety. Eaton et al. 2020 found that there is little evidence on the quality specifically of paramedics in advanced roles. O'Hara et al. 2012 found that ECP's care was safe regardless of the service that they operated in. Crouch and Brown 2018 identifies competency-based approaches with a shared curriculum valuing the unique contributions of different professional groups may lead to a richer skill mix whilst maintaining quality and safety. Broadening access to modified curricula and credentialing of individuals has been demonstrated through the ECACP. This offers a possible model for the future. Crouch and Brown 2018. Hooks and Walker 2020 agree that professional regulation is needed with standardisation of job descriptions. The level of practice and expectations is needed. This will clarify the ACP role and reduce risk of ACPs being asked to work out of their scope of practice, therefore improving public safety. This has not yet been formalised. Currently, the plan is for practitioners to continue on the register with their governing bodies, and they will then apply to be on a joint multi-professional register of advanced practitioners. Summary and action plan. There are numerous advanced roles within the ambulance service, but many are management focused and have left a void for those wanting to progress clinically. Pre-hospital emergency experience and skills in history taking and physical assessment have allowed paramedics to adapt well into advanced roles within hospital in emergency and urgent care. Once inducted into the hospital environment, they've become part of the valued, diverse and multi-skilled ACP team. Williams 2017 found that the differences in the remit, responsibilities and scope of practice of practitioners from different backgrounds is negligible. There is a general widespread issue with the ACP role that there is no set standardisation of scope or competencies, putting ACPs at risk of not knowing their boundaries and possibly being asked to work outside of their scope. This has become about due to the role being highly successful in many different areas and specialities and bridging the gaps from shortages of medical colleagues. Roles have evolved separately depending on the area. It is widely agreed that for practitioners and patient safety, there needs to be professional credentialing and registration to unify competencies and job descriptions. This needs to happen, but is a complicated process as it involves practitioners from different backgrounds, different regulatory bodies who are working across multiple specialities and areas with vastly different roles. Therefore, standardisation of the role may not come anytime soon. So to help protect my colleagues and I, there is a need to develop a clearer job specification and a list of competencies to identify a scope of practice of an advanced clinical practitioner within urgent care. These next two slides contain my reference list.